Welcome to the endoscopic ultrasound EUS F&B fine needle biopsy session with Dr. Ashley Faulx, Dr. Paul Corc, and we have our assistant here, Juan, and we're going to start with a few questions for you. And what is it that you're looking at, and what is it that you're doing?
Okay, so this is a linear echo endoscope. So this is the scope that we use for biopsying versus the radial scope, which doesn't have the capacity to biopsy. And we are in a pig's stomach here, and so right now you can see on the screen there it looks to be a fluid-filled substance. So when we're looking at, echo texture, when we're doing EUS, you can see that this is an anechoic looking structure, so that's how we describe things, as what their echo texture is. So using Doppler, you can see if this were the aorta, this would have an intense Doppler signal, but it does not. So it's anechoic with some hyperechoic debris in it, potentially gallbladder sludge. Sometimes you can see shadowing indicating stones. So that's the pig gallbladder. You can see there's an epithelial lining around it here that you can see this nice, bright white line. And when you're doing EUS, the easiest thing typically to see is the liver because it's very big. And it's a little harder to discern in the pig here because the gallbladder seems to be taking up the majority of the space. So I do have a balloon I'm going to inflate here on the probe. So you can see the liver is sort of a little hard to see. But so we're going to do a liver biopsy. Liver biopsies become a thing in EUS. We used to do it just more for biopsying metastatic disease or lesions in the liver, but now in patients where we're doing EUS maybe for another reason, doing portal pressures or doing a biopsy, we can also just biopsy liver parenchyma to assess for cirrhosis or anything like that, and we can also biopsy liver lesions. So there are no liver lesions in this pig, but we can do a biopsy anyway to show the technique.
A random liver biopsy.
Right.
It looks like you have a needle loaded up. What are your preferences for needles?
So this is a 19 gauge needle. It's not one of the newer generation needles, but it's actually very good for liver biopsy. It's the one that I use. 19 gauge is nice. You want to get a certain number of portal tracks, typically 5 or 6. So with these larger gauge needles, which are hard to use in the EUS scope, especially in the pancreas because the scope is torqued, when you're in a nice straight position like you are typically biopsying the liver, these needles can be, be used very easily. So for other areas like the pancreas, I typically use the 3rd generation needles, the Francine tip, fork tip needles that get, really nice pathology and not much blood. But this is what I do use for liver biopsy.
Very nice. Color flow, Doppler, anything prior to a biopsy? Yeah,
I usually do the Doppler, and I often take a picture of it. So to say, in my report, I'll say, Doppler was used to find a vessel-free path. And I like to just take a picture to sort of show that I've done that. So there's Doppler. Obviously, there's no flow anywhere in this pig, but if there were, you would be able to see signal and maybe differentiate between a bile duct and a blood vessel. So I usually try and just do a quick once, take a picture, and then I turn the Doppler off because it can degrade the image a little bit. And when you're going in with the needle, of course, you'll get all these reverberations that look like...
You see better without the color flow.
Exactly.
Nice.
So there are a lot of adjustments you can do on the EUS processor. If you want to zoom in, you can zoom in. You can change the depth of penetration depending upon what you're trying to look at. So there are a couple of adjustments, but a lot of this is sort of pre-programmed, and oftentimes they don't mess with it too much. A little bit of labeling if you're a labeling person or not. I'm not a big labeling person.
Can you go over left and right lobe, gastric transduodenal approach? What was your preference?
Usually it's a transgastric approach because, again, the scope is nice and straight. The gallbladder, although we're seeing it very well transgastric here, typically you're seeing it more in the antrum. You can see it in the bulb, depending upon if you want to drain the gallbladder, which I think everyone probably saw in the prior session. So typically it's a transgastric approach. And again, it's sort of easy because it's pretty straight. And you're pretty high up in the stomach when you're looking at the liver. And it's mostly left lobe that you're seeing. You typically, much harder to see the right lobe. And to be honest, I'm not really, I don't think that I could tell you if I was looking necessarily at right versus left, but I don't know. Yeah. I don't know what you guys think. what your thoughts are on that topic.
Yeah, some advocate for biopsying both right and left lobes, but I don't. I actually do, but I don't know the data if one is better than the other. I just like the sample I get from the right lobe. You can sometimes get a longer needle pass.
All right.
We'd love to see how you do it.
Okay.
Can you show us how?
Sure. So again, you're finding a vessel-free path, and you want to adjust your needle so that you know, you don't go too deep. But in this, I've found that I need to kind of adjust it pretty far down. And so I'm looking to see the needle come out, and I first like to see what the trajectory is. Do I like it? With this needle, I try not to use the elevator much because it is a really stiff needle. If you need to change your angle a little bit, you can angle it up a little bit. And then it's sort of a hard jab. I always tell the fellows when they first start, they're kind of being tentative, and you'll basically just tent the stomach away like that. You won't get through. The stomach is pretty thick-walled, so you really have to give it a good jab. So that's why I like to use this guard to make sure that I don't go too far. So you can kind of give a quick jab. So there you can see you're in the liver, and that went pretty easily. And then there are different ways of acquiring the tissue once you're in. There's the old-fashioned way, I would say, when I first started, was you took the stylet out, and you put the syringe on and turned on suction and did your back and forth. Then it sort of moved to the slow stylet pull, which we'll show here. So basically, as I'm moving the needle, actuating it forward and back, with forward being the sort of tissue collection phase of moving your needle, and then we do a slow pull. And basically, it sort of works as like capillary action, where the tissue is coming up into the needle as we slow pull. So if you're feeling like, maybe I need to do something more, which we typically don't do for pancreas or lymph nodes or anything like that, you can add suction. So there's a suction needle or a suction syringe that comes with this needle, which you can screw on the tip of the needle, and then you open up the syringe. It already has suction here, so you just open, and then again you can sort of go back and forth here with your needle. So typically, for the liver, we typically do a wet suction, which is basically you take the stylet out before you go in, you fill the needle with saline, some people do heparin, and then you're basically going to turn on suction, and seems to preserve a nice, better core perhaps than just dry suction or the stylet withdrawal technique. So it sort of depends upon what you're in. Typically suction will cause you to have a bloody sample if you're in a lymph node, has been my impression. So I usually do slow stylet pull for most of my FNBs, except for liver where I do wet suction. I don't know, do you guys have any other thoughts?
I completely agree. That sounds very typical. I really prefer slow pull for lesions of any kind.
Do you put the color flow back on as you're pulling the needle out? Do you ever put a plug back in if you're seeing blood? We've seen some really fancy work with putting tissue back to plug it in. Nope,
I do not do that. I have not had any problems. I think if you're going into a vessel, you know, we think about it. If you're doing portal pressures, watching as you come back, making sure that you're not creating a fistula. No, I have not had an issue with that.
Perfect. Can we see how you extract the specimen and how you handle?
So we turn off the suction. Perfect. And then, you know, the goal is not to stab the tech. Very important. Okay, so we're going to remove the needle here. And so everybody's a little bit different. I'm a little bit of a control freak about my specimens. I like to do it myself. So I usually hand the nurse or someone in the room the scope, or honestly, when they're intubated, I just lay it on the patient, which is probably not right.
Please show us how you do that.
Okay, and then, so I like to make my own slides, but we're gonna do something a little bit different here. But basically, you're gonna put the needle out a little bit. Again, make sure not to stab anyone. Ready. And then I usually have, you know, a set of slides. So I'll do, depending upon how much I really want to look right at the time versus putting most of it in formalin or Cytolite, I'll sort of maybe make a couple sets of slides. Sort of depends upon what it looks like when it comes out. If it's like, well, blood, move to the next one, move to the next one. So I'm a little variety there. So we stick the needle out a little bit, and then we'll get our slide. This is a special slide that we have here. And then we use the stylet because we want to slowly express the material onto the slide. So if I want to do a touch prep with a little bit on the slide and do the rest into formalin or cytolite, I don't want to blow it all onto the slide. The other option would be blow it all onto the slide and then pick out parts that you want putting in different media. Some people also use slide paper and can rinse the specimen if you get a nice core to keep a bunch of blood from coming out.
So we can see you have a very nice specimen there. We're going to have Dr. Corc review what we do with the specimen using neo-imaging.
Okay, so I'm going to show this Neo device that we've been using at our hospital. We call it our washing machine. It sits in the hallway. But it's a really neat device. It's going to give us real-time histology with our sample. It's very easy. We just drop the sample on a little slide, put it in the machine, and we can acquire histologic image, computerized digital image. So up here we have a previous biopsy of a neuroendocrine tumor of the pancreas. So we normally wouldn't do this for a liver biopsy because that's just going into formalin. But any type of lesion, especially pancreatic adenocarcinoma, we can get very rapid preliminary interpretation without waiting for the pathologist to call or come to the room. So it's very fast. We've done a pilot study at our hospital on 20 patients in the pancreas, and this is technology that's used around the world in mostly in brain tumors thus far, as well as some pulmonary cancers. So we're trying to apply it to the pancreas. And then I think in the future, the goals would be AI interpretation of this, as well as the amount of cellularity, so we know that we're getting a sufficient sample both for diagnosis and even next generation sequencing.